You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is January 6, 2025. Our topic is Abbas Chapter 13, Effector Mechanisms of Humoral Immunity. This is presented by Dr. Nikita Raje. She is an Associate Professor of Internal Medicine, Pediatrics, and is the Chief in the Section of Allergy Immunology at Children's Mercy Hospital in Kansas City, Missouri.
Again, I'm Nikita Raje from Children's Mercy Kansas City, University of Missouri, Kansas City. Here's my email in case you have any questions or comments. And today is January 6, 2025. We'll be talking about effector mechanisms of humoral immunity, Chapter 13 from Abbas. All right, my disclosures haven't changed. Objectives for this chapter is to talk about, now we talked about activation of B cells. Now we'll talk about how the humoral immunity comes into play. It uses neutralization of toxins, opsonization, and phagocytosis, and then complement system that helps in that humoral response. Few questions. Which of the following functions of antibodies does not require Fc receptors specific for IgG? Children with C3 deficiency are at higher risk for serious bacterial and fungal infections. Which of the following explains the importance of C3 in defense against these microbes? All of the following are accurate statements about neonatal immunity, except. The except questions are always tricky. A 15-year-old boy with a history of multiple episodes of severe abdominal pain is found to have intravascular hemolysis, including hemoglobinuria and elevated retic count. Further workup included flow, showed a lack of cell surface GPI linked protein. Diagnosis of PNH was made, and what is the basis of the loss of RBCs in this patient? All right, so we just finished talking in chapter 12 about B cell activation and the various ways the processes that are required, like isotype switching or affinity maturation, at the end of which high affinity class switched antibodies are produced. We know that humoral immunity is mediated by these secreted antibodies. Antibodies are our defense against extracellular microbes and microbial toxins. So that word extracellular is very important because antibodies cannot take care of a microbe in its intracellular phase. Defects result in increased susceptibility to infections with various microbes such as bacteria, fungi, viruses. And unfortunately, antibodies can also mediate some tissue injury that leads to atopy and autoimmune disorders in different situations. Let's talk about vaccine-induced humoral immunity. So here are the various types of disorders and their vaccines, and they are all different kinds of molecules, and that makes a difference for T cell response because the T cells only respond to protein antigens. In case of humoral immunity, these vaccines can be of different types, such as toxoids in case of tetanus and diphtheria. They can be recombinant viral proteins like hepatitis A or B. They can be conjugate vaccines for some polysaccharides like pneumococcal, or they can be a pure polysaccharide for pneumococcal, or they could be a conjugate, as I mentioned, for any of these. Pneumococcal, Hep, Neisseria, all of these can be conjugated vaccines. Depending on the type of molecule or the vaccine, the mechanism that's used can be different, such as in case of toxoids or recombinant proteins, there are or full protein. Basically, the vaccines lead to generation of immunoglobulin production like IgG or IgA that leads to neutralization of the microbe or the toxin. The mucosal IgA is also will produce similar effect. For some of the conjugated vaccines, there can be opsonization and phagocytosis that's mediated by IgM and IgG, either directly or through activation of complement. All right. So, antibodies act at sites that are distant from where they are produced, right? The B cells produce antibodies, then those can go into the circulation and they can end up in various tissues and they can produce their action or effective function at those sites. The various different functions are neutralization, opsonization, and phagocytosis. They can produce antibody-dependent cellular cytotoxicity, phagocytosis with the help of complement. Once the complement is activated, there can be inflammation or lysis of the microbes. We know these effector functions can come from these antibodies that are produced by plasma cells, and the effector function itself is a function of the FC region of the antibodies. FAB regions help in antigen recognition and that activation part, but once activated and differentiated, the antibodies that are produced are the function of the secreted antibodies have the function is based on their FC region. So FC region gives rise to various isotypes. So each of these isotypes have their specific effector function that's different. In case of IgG, which has the wide variety of functions like opsonization or antibody-dependent cytotoxicity, activation of complement. It also helps with neonatal immunity as well as did I say neutralization? I already did. They also provide feedback for B cell activation. Versus IgM is important for activation of classical pathway of complement. IgM is the most potent activator of complement and fixer of complement. IgA is important for mucosal immunity, helps in neutralization of microbes and toxins, and IgE helps in mast cell degranulation and eosinophil-mediated response. So let's talk about each of these functions. First one is neutralization. So when a microbe comes to the surface, there is something called steric hindrance, which means the antibodies can say there is a tetanus toxin or diphtheria toxin. The toxin itself cannot bind to the surface or the cell that it binds to because the antibody is bound to that toxin. That means it interferes physically with that particular region. Or if there is an antibody that binds to the pili of the gram-negative bacteria, the pili cannot bind to the surface. Or for influenza virus, these antibodies bind to the influenza virus so that they cannot interact with the respiratory epithelial cells. Apart from steric hindrance, some of the antibodies can also produce an allosteric effect, which means there is an induction of conformational change in the microbial surface, but even though the antibody itself is not binding to that part. That is called allosteric effect. Let's see, in this figure here, antibody blocks the penetration of the microbe through epithelial surface or the toxin. It cannot interact with it because the antibody is bound to the toxin, so it cannot bind to that cell surface toxin receptor. Or here is a tissue cell antibody blocks the binding of the microbe and the infection of the cells. So again, two types of neutralization, by steric hindrance and allosteric effect. Second function is opsonization and phagocytosis. Opsonization is a process of coating the particles to promote phagocytosis, which means it decorates the surface. That's what the opsonization literally means, decorating the surface, typically for eating, which means that it's decorating it so that it can be phagocytosed. And the substances that perform this function are called opsonins. Apart from antibodies, there are other opsonins like complement fragments. We know that IgG1, IgG3 are the most efficient opsonins, and Fc gamma R1 is the receptor for phagocytosis of opsonized particles. So let's look at this figure. Here is um, a microbe that is opsonized by IgG antibody. Now the Fc region of that antibody can bind to cells that it's specific for, like IgG can bind to phagocytes. Now that it's bound, the opsonized microbe that is attached to the IgG will come in contact with this phagocyte, because the FC receptor on the surface of phagocytes can bind to these IgG antibodies. Because of that, the macrophage will get activated and it's gonna form a pouch so that it can phagocytose or eat up that microbe so that it's inside the macrophage at this point. That is your opsonization and phagocytosis. We talked about different Fc receptors. Here is a list of all of those receptors. Each of these receptor has that chain or the isotype chain mentioned in them. So Fc gamma, Fc alpha, Fc epsilon receptors are mentioned here. Fc gamma receptors for IgG are different types: Fc gamma R1, R2A, R2B, R2C, and R3A, R3B. Among these, all of them are activating signals, whereas Fc gamma R2B is the only one that provides feedback inhibition. Now, if you notice, they are numbered. They have a second name CD marker attached to it, and it goes in reverse fashion. So 16, 32, and 64 are the numbers. So double them up, 16, 32, and 64, and they are in the reverse order. So Fc gamma R1 has the highest number, CD64. Fc gamma R2 has CD32. Whether it's A or B, it has the same CD marker, or C, same CD marker. And then FCR3 has the marker CD16. So Fc gamma R1 is the high affinity receptor for IgG and leads to phagocytosis. FCR2A and C are also help with cell activation and phagocytosis. As I mentioned, R2B, CD32 Fc gamma R2B provides feedback inhibition for B cells, and then Fc gamma R3A is on NK cells, so it helps with antibody dependent cellular cytotoxicity, or ADCC. That's your CD16. Remember, NK cells have CD16 and CD56. Those are the markers that identify NK cells. And so Fc gamma R3A can bind to these NK cells and provide antibody-dependent cytotoxicity. All right, and then R3B is low affinity receptor that also helps in phagocytosis. So among all of these, Fc gamma R1 is the one with high affinity binding for immunoglobulin. Rest are low affinity for Fc epsilon. So we are talking about binding of IgE to using its Fc region to this receptor on mast cells or eosinophils or basophils. Right, these cells typically have Fc epsilon R1 and can bind to IgE with high affinity and lead to degranulation. Fc epsilon R2 is CD23. It binds, we don't know the function of that. And Fc alpha receptor is for Ig binding with low affinity to IgA antibody. So again, important to memorize these numbers. function of some of these that you have to memorize, especially R2B, R3A, that have different functions. Rest of them help with phagocytosis and activation. All right. Talking about these Fc gamma receptors, R1, R2, R3, they are based on affinity for IgG subclasses. They contain an alpha chain and some associated with other chains, right? So Fc receptor gamma has this chain that has CD32 on it. That's your R2A and C. There's also CD64, which has an alpha chain, and Fc gamma R3A that has an alpha chain. Lot of these, have alpha chain on them, but they can associate with gamma chains or gamma zeta chains in some cases to form that full Fc receptor. Your R3B is the one with CD16. All right. Most of these have that item on the cytoplasmic tail that helps in activation. Fc gamma R2B is the inhibitory feedback receptor, and that has an item on the cytoplasmic tail. Remember ITAM and ITIM. ITAM is the activating motif, immunoreceptor tyrosine based activating motif, and then ITIM is the inhibitory motif. Else on this that's different. We talked about R2B having ITIM, A and C having ITAM, CD16, which is R3, R3A and R3B that have CD16 on them. A form is has the other proteins and helps with ADCC. B form has a different structure. We don't know the function of that. R2, we talked about that. CD32, well, we talked about that. Sorry, don't know what happened here. All right, neonatal receptor, FcRn. N stands for neonatal. It was thought to be present in the placenta and help with passing on the immunoglobulin G from maternal circulation across the placenta. That's how it got its name, FcRn. We know that it's also present in some of the mucosal tissues, also helps in passing on the immunity or immunoglobulin A in breast milk. This immunoglobulin receptor has, or Fc receptor, has specific qualities that makes it unique. It is IgG specific and requires a acidic environment, right? And its structure, if you remember the structure of MHC class 1 molecule, it is similar to that. It has that beta-2 microglobulin bound to a single chain that has that binding cleft here. So it's very similar to MHC class 1. And the important fact is, apart from neonatal immunity, in adult life, it continues to bind to IgG so that it can give long half-life to IgG because it's bound to the immunoglobulin G. It takes longer for the IgG to be available for catabolism. That way, IgG is protected. So what happens, say here is the maternal circulation, here is at the bottom is the fetal circulation. At physiological pH, this immunoglobulin moves towards the syncytial trophoblast. In there, in the early endosome, it gets bound to the FcRn, and then in that, because the endosome is acidified, it continues to stay there, and then later gets released to, it goes closer to that to the membrane where fetal circulation has physiological pH, where it gets released. Because of that, it can help with neonatal immunity, but also because of this kind of process in other mucosa, immunoglobulin G, because it's bound to in the endosome for a longer time, it gives a half-life about 3 to 4 weeks. Talking about antibody-dependent cytotoxicity, antibody binds to the antigen expressed on the surface of the cell, infected cell, and then CD16 on NK cell binds to that antibody-coated cell so that it becomes a target cell for the NK cell. So here is your cell that's infected, and it's coated with the immunoglobulin. That immunoglobulin will bind to Fc gamma R3 on the NK cells, because of which it can interact with this cell as a target cell and can kill that cell. We're talking about IgE here. Worms or helminths are too big for phagocytosis, so neutrophils and macrophages may not be enough, but they can be killed by chemicals like cationic protein or major basic protein in eosinophils. IgE can bind to the helminths, and then they can bind to the Fc receptor on the mast cells and eosinophils and help in degranulation of those cells so that they release all their chemicals like the cationic protein or the major basic protein. Now we talk about the complement system. Complement system is a effector mechanism of both humoral and innate immunity. We talked about the alternative complement pathway and lectin pathway, which are part of the innate immune system. For humoral immunity, the antibodies activate the classical pathway, and that's your classical pathway is part of the humoral response of the complement system. Regardless, the complement system promotes phagocytosis of microbes, stimulate inflammation, and induce lysis of the microbes. Complement proteins are small proteins. They are present in the plasma, and they can bind to each other to generate bigger enzyme complexes with proteolytic activity. So the small proteins that can bind to each other are called zymogens, and they can bind to each other to give rise to bigger immune or enzyme complexes. These complement proteins can be activated by in various ways. It could be antibodies, it could be microbes themselves. They are important for different types of complement cascades of what activates them. Talked about zymogens, and they are activated. Once they are activated, they'll make bigger complexes. Also, the activation is inhibited by some regulatory proteins that are present on normal host cells, but they are absent in microbes. So microbial surface will get targeted by the complement cells, but our own host cells don't get targeted because they are protected by these regulatory proteins. Talking about complement activation, there are three pathways: classical pathway, alternative pathway, lectin pathway. Classical pathway is activated by antigen-antibody complex. Alternative complement is activated by the microbial surface, and the lectin pathway is activated by the lectin. All of these result in making enzyme complexes. So the initial cascade is different for each of them. But once they form the enzyme complex, the first step is to form a convertase that will generate C3A and C3B. That's called C3 convertase. And then the next step is to form C5 convertase that generates C5A and C5B. These are the two major steps. Each of the cascade has these steps, but the C3 convertase and C5 convertase may differ for both of these, or for all of these pathways. All right, so let's talk about here. They show how there is a difference, but regardless of what kind of convertase, each of them need the C3 convertase that interacts with more C3 to form C5 convertase, and then ends up in this final cascade that leads to formation of membrane attack complex in each of the pathways. But if you see at the top, the initiation may look different for each of these cascades. All right, alternative pathway. The important protein is C3. C3b binds to the surface of the microbe. So C3 is continuously being dropped and is being converted to C3a and C3b. C3a is the smaller particle that stimulates inflammation and is called anaphylatoxin. C3b is the fragment that binds to the surface of the microbe. So unless a cell is protected by regulatory proteins, which the microbial cells are not, the C3 will come and bind to it. And it functions as an opsonin and as a component of C3 and C5 convertase, right? That's your C3b. Apart from that, the alternative pathway also needs factor B. B, activated form of BB, is a serine protease. And so it helps in formation of those enzymes, active enzymes of C3 and C5 convertase, right? So that's your factor B. Factor D is a plasma serine protease that cleaves factor B when it is bound to C3b. So when factor B gets bound to C3b, D can come along and cleave factor B so that it forms that factor B fragment. Propyridine stabilizes C3 convertases on the microbial surfaces. So it's almost like a regulatory thing. Propyridine defect is X-linked and it can lead to immunodeficiency. Of course, C3 defect, there are a lot of complement fragment defects that can lead to complement pathway defects, immunodeficiency. Propyridine is one that's X-linked, but defect in C3 can also lead to immunodeficiency, for example. All right. So C3 is constantly being cleaved to C3a and C3b. C3a is our anaphylatoxin. C3b is the one that we are is important for the complement cascade. It's continuously being dropped, and any surface that's not protected will get attached to this C3b. So it will try to bind to host cells, but the host cells are protected, so it cannot do anything about that. But when there is a microbial surface, it can bind to it and can opsonize it. C3b bound to, here is the C3b. Now that it's bound to the microbe, factor B comes along and binds to that. Factor D comes along and cleaves this B to BA and BB. BB continues to stay connected to C3b. This complex is the C3 convertase of alternative pathway. When this as the name suggests, C3 convertase helps in being very efficient and cuts up a lot of molecules of C3 to C3a, C3b. So it's way more efficient here than what was being C3b being released up here. So now that it's an efficient process because it's bound to the microbe, lots of C3b are being dropped, and those come and connect to the C3b-BB complex. That complex with C3b, 2 molecules, and BB together form the C5 convertase. Now this complex will help in cleaving C5 to C5a and C5b. All right, moving on to talk about classical pathway. We are talking about the initial cascade of each pathway, and then we'll talk about the final common pathway. For classical pathway, there is C1. C1 has various fragments, C1q, C1r, C1s. There are 2 molecules of R, 2 molecules of S, and 1 molecule of C1q that come together to form the C1. This helps in initiation of classical pathway. We'll look at it in a few minutes. So C1q is the one that binds to the Fc portion of antibody that has a bound antigen. So antigen-antibody complex, the C1q binds to the antibody of that complex. It can also bind to some of the other surfaces and apoptotic cells. C1r is the one that has the enzymatic action. Serine, it's a serine protease that can cleave C1s. and to make an active protease. And C1s is a serine protease that cleaves C4 and C2. So C1R is required for the function of C1s. C1s is the one that will cleave C4 and C2. C4 is when it is cleaved to C4b and C4a. C4a is a smaller one that acts as an aflatoxin. C4b is the one that will bind to the microbe. And C4b binds to C2 because C2 is, along with C4b, will help in the function of C1s. All right, C2a is the serine protease that functions as the active enzyme of C3 and C5 convertase to cleave C3 and C5. Here is that complex. C1q is this whole structure, and the small structures are C1r and C1s, 2 molecules of C1s, 2 molecules of R, and the C1q all together form the C1 molecule or complex that binds to antibody bound to an antigen. That's where the process starts. Then the C1s will cleave C2 and C4 and that are important for the function of the classical complement pathway. Now C1q must bind more than 2 Fc regions, so that's important. So it only binds to a complex, antigen antibody complex, because if it's a free-flowing antibody, it cannot fix complement. Fc region of soluble IgM is not accessible, which means when the IgM binds to an antigen, that's when it has more than one Fc region so that the complement can bind to it. All right, same thing for IgG, same thing for IgM. It needs 2 Fc regions. C4 is similar to C3, which means C1s cleaves C4, C4a, and C4b. C4b is the one that has this bond called thioester bond that remains bound to that complex microbial surface. C2 comes along and makes C2a comes and binds to C4b, and C4b, C2a together is the C3 convertase. Now this convertase means that it can cleave C3 molecules to C3a and C3b very, very efficiently. So there are multiple of those. One of that fragment can attach to this C3b bound to C4b and C2a, makes the C5 convertase, and C5 can now cleave C5 to C5a and C5b. So the convertase in alternative pathway was C3b, BB, C3b. In case of classical pathway, C4b, C2a, C3b is the C3 convertase. Or sorry, C5 convertase. Third pathway is lectin pathway. Here the mannose is the sugar that lectin is targeting. So mannose binding lectin is your major protein that we are talking about in this pathway. It also interacts with these proteins like MASP1 and MASP2 that have the serine protease action. Also, there are ficolins that have similar kind of action. Instead of targeting mannose sugar, they might be targeting another type of glycosamine. N-acetylglucosamine, sorry. So that's your ficolin. We are talking about MBL pathway. MBL pathway has this same kind of structure, but this is not C1q, this is MBL. These two structures here are not C1s or C1r, they are MASP1, MASP2, but very similar concepts and very similar structure. Similarly, there is a third type of pathway called ficolin. Ficolin has the same structure as C1q and is interacting with MASP1, MASP2. Mannose binding lectin binds to mannose residues and ficolin binds to N-acetylglucosamine. All of these mannose and glucosamines, these are not part of typical human cells. So these pathways are targeting, they are smart enough to target molecules that are mainly on microbial surfaces, like fungal wall or bacterial cell wall. All right. Now we talk about the final common pathway. For each of these pathways, for MASP1, MASP2, they act like C4A and they help in the same kind of process where the instead of C1Q, C1R, C1S, that complex interacting with C4 to cleave C4A C4 to C4A, C4B, it's going to be this MBL, MASP1, MASP2 that will cleave C4 to C4A, C4B, and C2A will bind to C4B. Rest of the pathway is very similar to the classical pathway. So regardless of all which pathway is activated, the final step is C5 convertase that cleaves lot of C5 to C5A, C5B. And that starts the final common pathway where the C5b initiates the assembly of membrane attack complex. C5a acts as an anaphylatoxin. C5b that started the formation of membrane attack complex will incorporate C6, 7, and 8 to form the membrane attack complex. And that inserts into the lipid membrane of the microbe. Apart from these C5b, C6, C7, there are multiple molecules of C9 that come and bind to these molecules, C5, 6, 7, 8, and forms the hole in the microbe. Let's look at that. C5 was cleaved to C5A, C5B. Whichever complement pathway you take, you have C5 that's cleaving to C5A, C5B, and to that complex is added C5B, C6, C7, C8. Once these are incorporated, multiple molecules of C1Q come to make a hole in the membrane of that microbe. So that causes the cell lysis. All right, complement receptors. These complement fragments can bind to its receptors. There are 4 types of complement receptors, CR1, CR2, CR3, and CR4. That's very intuitive, but the CD markers are not. You have to remember these CD markers. There are also other names of these receptors. One thing to remember is CR3 and CR4 that have CD18 in them. They are, if CD18 is defective, as you see in LAD, leukocyte adhesion defect, then CR3 and CR4 will be affected. CR2 is your complement receptor that is a receptor for EBV. It is also a co-receptor for B cells. So B cell co-receptor has CR2 as a part of it. Its CD marker is CD21. So again, something to memorize. CR1 is CD35, helps with the typical functions of complements, phagocytosis, clearance of immune complexes, and things like that. There are some regulators of complement activations like C1 inhibitor. Defect in C1 inhibitor leads to hereditary angioedema. Factor I, factor H are also regulators of complement. Defect in factor I, defect in factor H can lead to immune defects. Factor I defect can lead to infections. Both of them cause atypical HUS. Factor H is a cofactor for factor I. Factor I is the one that is a serine protease that cleaves C3b and C4b. So C4b and C3b are trying to make a complement activation and formation of membrane attack complex. But if factor I gets activated, it will cleave these so that the complement activation is stopped. That's the function of factor I. Factor H is a cofactor for factor I. C4 binding protein also binds to C4b and it displaces C2. So the classical complement pathway will not continue to progress. It is also C4BP is also a cofactor for factor I. MCP, membrane cofactor protein, or CD46 is a cofactor for factor I. Decay accelerating factor displaces C2A from C4b and BB from C3b. That helps in stopping, so dissociation of C3 convertase, that's your decay accelerating factor. And CD59 can act even if the whole cascade goes through. CD59 can block C9 from making that hole in the membrane attack complex. So that's your CD59. It interacts with C7 and C8. All right. We looked at this. What does C1 inhibitor do? It's a serine protease inhibitor, and it can come and prevent C1R2 and S2 from becoming proteolytically active, right? So that C1 inhibitor is targeting this little complex here. C3 convertase, here we are talking about all of these: factor H, C4BP, decay accelerating factor, CR1, MCP. All of these are targeting this step, formation of C3 convertase. And defect in decay acceleration factor leads to paroxysmal nocturnal hemoglobinuria. Factor I is a serine protease. It mediates cleavage of C3b to I, or inactivated C3b, C3d, C3dG, all kinds of cleavage, products. And it interacts with its cofactors that are MCP, factor H, C4BP, CR1. They all help factor I. Deficiency leads to the infections with pyogenic bacteria. CD59, it causes problem in that last step of C9 insertion. And then protein S binds to C5b, C6, and C7 and prevents their insertion into the membrane. That's your S protein. Effector functions of complement: it leads to lysis of the cell by membrane attack complex. It helps in opsonization by binding to the microbe, and then helps in inflammatory response through those anaphylotoxins, and it also helps in clearance of immune complexes. That's your membrane attack complex that then finally makes a hole in the cell and leads to lysis of the bacteria. Opsonization and phagocytosis, we already talked about. It can bind to complement receptors or maybe antibody receptors, depending on whichever one that is targeted on the phagocytes. Inflammation, C3a, C5a act as anaphylotoxins, activate various cells, mast cells, neutrophils, endothelial cells, and lead to a lot of cells coming to that surface and lead to increased permeability. All of that causes inflammation. And then helps in removal of immune complexes. So it can target cells such as erythrocytes, red blood cells that will be targeted, and they can be phagocytosed. So immune complexes will be phagocytosed because they are tagged by these complement receptors. They also help in activation of B cells. We know that CR2 is part of the co-receptor for B cells. Can you guys hear me? Making sure that you guys are still able to listen to me. Okay, all right, yeah, all right. So there is activation of B cells where the C3d fragment that's bound to the antigen can come and interact with the complement receptor 2, that is a part of the co-receptor for B cell receptor, helps in activation of B cells. All right, coming and talking about the complement deficiencies. C2 deficiency is one of the most common immunodeficiency. C1q, C2, and C4, these can be defective in systemic lupus erythematosus. C3 defect is also one of the common complement deficiencies that lead to pyogenic bacterial infections. Factor D defect, propyridine defect, these are part of the alternative complement pathway. These can be defective and can lead to pyogenic bacterial infections. Mutations in MBL gene, lectin pathway defect. It can lead to immunodeficiency. However, it's very common to find someone with low MBL level, and typically those patients can be walking around fine. So we think that this is not a true immunodeficiency. However, it does exist where there are patients who are walking around with low MBL pathway proteins. However, it typically does not cause infections and does not need treatment. Terminal components, I should mention that that's controversial. So there are two schools of thoughts, and some people do treat MBL pathway defects. Terminal components C5 to C9 defects, those are the ones that will lead to typical terminal complement pathway defects that we identify by their association with these infections by disseminated Neisseria and encapsulated organisms infections. Factor H defect can lead to glomerulonephritis. Mutation in factor H can lead to atypical hemolytic uremic syndrome. And it can also lead to age-related macular degeneration. Complement receptor defects, LED, can lead to defect in CR3 and CR4. Immune complex mediated diseases because of complement defect can lead to systemic vasculitis and glomerulonephritis. Deposition of antigen antibody complexes in vessels and kidneys that lead to that vasculitis and glomerulonephritis. And then, there are some microbes that actually are easily able to evade complement system. They can have thick cell walls so that the complement cannot act on those walls, like gram-positive bacteria, some fungi. They recruit host complement regulatory proteins. So they recruit factor H in displacing the C3b from BB. That leads to, then they can actually act on that, cell, and they can infect that cell because it used the regulatory proteins against the complement activation. That leads to expression of sialic acid. HIV expresses GP41. HIV incorporates the DAF and CD59 so that actually it can infect that cell. And then there are some microbes that act like complement. They have proteins that act like complement proteins. So E. coli has C1q binding protein. It inhibits the formation of this whole complex, C1 complex. Staph aureus has staph complement inhibitor that binds to and inhibits C3 convertase. HSV has this glycoprotein C1 that prevents C3b from binding to piperidine. Trypanosoma can bind to C3b and prevent formation of C3 convertase, and vaccinia virus can resemble C4b binding protein, binds to C4b and C3b and accelerates the decay of C3, C5. So on and so forth. There are various proteins in various microbes that can bind and evade complement. Few questions in last few minutes. Which of the following functions of antibodies does not require Fc receptor specific for IgG? Which one is not? Anyone?
I'm not sure about this one, but I'll go with choice C, antibody-mediated feedback inhibition of B cells.
So that does require FcR2b, right? That's your feedback inhibition. So it requires that Fc receptor. So neonatal immunity requires FcRn. ADCC by NK cells, option B, requires Fc gamma R3b, R3a, so CD16. And phagocytosis requires Fc gamma R1 for high affinity. Neutralization is just binding of the antibody to the toxin itself. It does not require the toxin, that Fc immunoglobulin, to bind to Fc receptor. So the answer is E. So rest of them require the antibodies to bind to the Fc receptors. Neutralization the antibody just binds to that toxin. Children with C3 deficiency, which of the following explains the importance of C3 in defense against these microbes?
Is this one A, fragments of C3 generated by both classical and alternative?
Yeah, it's part of both classical and alternative pathway, not just classical or not just alternative pathway, and does not act as ligand for NK cells. So, and then the last option is talking about helper T cell cytokine secretion. So now, all of the following are accurate for neonatal immunity except anyone?
I'm not sure about this one, but I'll go with C.
I think it's B, absorbed in the gut from birth.
I think you're muted, Dr. Raje.
Sorry about that. Yeah. So IgA secretion into breast milk involves transport through breast epithelial cells. It's dependent on poly-Ig receptor. It doesn't get resecreted into bronchial mucosa. Right. And then last one is about PNH. What is the basis of loss of RBCs in this patient?
I think it should be choice C because you have an issue with the DK accelerating factor. The choice C.
Correct. Yeah. So